Good evening. Good evening,
Good
sir.
evening, Dr. Sandeep. Yeah, good evening, everybody.
Yeah. So you're all welcome to the 69th edition of our INOC DigiConnect webinar. And today it is an important day for every one of us because the topic is very significant today. And today there are two topics basically. One is our regular COVID-19 Epid updates, and the second is the WHO ILO joint estimate on COVID-19, which was just released yesterday, and the occupational risk factors. So today's session we will discuss the two reports which were published detailing the first set of the total WHO ILO joint estimates as well as the data sources and methods used. So these are the two topics with which we have planned today's webinar so that every one of us, they get the latest knowledge about all these issues which have just been released by the WHO and ILO. So, and for this, the faculty for this particular session and for these particular two topics is our Vice President AUSD, Dr. Rajiv Kumar Jain, sir. So we all know Dr. Rajiv Kumar Jain, and I don't think I have to again and again introduce him. He is a member of the Management Committee, Scientific Committee of Epidemiology in Occupational Health, that is EPICO, and which is International Commission on Occupational Health Scientific Committee, and he is also Vice President of Association of Environment and Occupational Health, Delhi. So may I request Dr. Rajiv Kumar Jain, sir, to start his deliberations so that we can know about the latest developments which have taken place and about the COVID Epid updates also.
Good evening, friends. Today we are meeting with a dual purpose. Besides the regular COVID-19 epidemiological updates, we shall take a stock of an important landmark where World Health Organization and International Labour Organization have for the first time brought out jointly the estimates on 19 occupational risk factors, 19 occupational risk factors. And we shall take up each occupational risk factor separately and see what is the data and what is the evidence and how it will contribute to better occupational health practice in the world, in the countries of the WHO and ILO. Because unless we know what is the extent and where actually these risk factors occur, we cannot plan an interventional strategy or have a policy where we are able to control or reduce or eliminate these risk factors to ensure better occupational health and better working conditions for our workers. And it is not only important for India, it is also important for other developing countries and also equally important for the developed world. Because for the first time ever, the WHO ILO jointly have brought out these estimates, which detail from the year 2000 to 2016 as to what is the contribution of each risk factor to cause death and also cause disability adjusted loss of life years. So this particular aspect we shall be taking today. So as we start today, I would like to start with a talk by Director General of the World Health Organization, Dr. Tedros, where he is introducing the subject, and let's hear him first before we proceed further.
Dear colleagues and friends, after 5 years of work, Today, we launched the first set of WHO-ILO joint estimates on the work-related burden of disease and injury. We estimate that more than 1.9 million people die every year due to exposure from risk factors at the workplace. It's shocking to see so many people literally being killed by their jobs, especially because every single work-related death is preventable with the right health and safety measures in place. More than 80% of work-related deaths are due to non-communicable diseases, primarily cardiovascular and respiratory diseases, which are caused by or made worse by factors in the workplace. Long working hours are the single deadliest occupational risk factor, accounting for 750,000 deaths each year. Work-related disease disproportionately affects men, older age groups, and the regions of Africa, Southeast Asia, and the Western Pacific. This joint report is a wake-up call to countries and businesses to improve and protect the health and safety of workers by honoring their commitments to provide workplace health promotion and universal health coverage of occupational health and safety services. Governments must work with employers and workers to ensure that workplaces are safe, respectful, and healthy environments. Nobody should die for their job. I thank you.
Well, after listening to the Director General of the World Health Organization, let's hear the Director of the World Organization, Dr. Maria Neira, who is the Director, Environment, Climate Change and Health, along with the Technical Officer, Dr. Frank Pigot, what they have to say about these joint estimates. This is a short video where you will get the background information and why it is important to understand these estimates for our occupational health practice. So there is a 4-5 minutes video which will tell you the background information before we go on to actually get to see the estimates as they are. Dr. Frank Pigot and Dr. Maria Neira.
Why this report? Okay, for many years, of course, the collaboration between WHO and ILO has been very fruitful and very close, but we were producing separate estimates. Then we decided by joint expertise of ministers of health, ministers of labor, and more than 220 individual experts, we could produce these joint estimates that we are presenting today. And we think that this is the first time that have been produced, and not only that, they represent the most comprehensive set of official estimates of work-related the burden of diseases to date.
Thank you, Dr. Neira. Before I introduce the next speaker, I'd like to let
The occupational risk factors has caused almost 2 million deaths globally in 2016. This is a terrible figure because, as mentioned already, many of those deaths could be prevented. If we go to the detail now in these 2 million deaths, we can tell you that 80% of those work-related deaths are caused by diseases, means all of those diseases being non-communicable diseases.
two.
Almost two.
No, this video should keep playing.
Pollution resulting on chronic obstructive pulmonary disease. That was responsible for 450,000 deaths. Exposure to long working hours and a stroke was responsible for 400,000 deaths. And exposure to long working hours causing ischemic heart disease was responsible for 346,000 deaths. Therefore, the single the single largest risk factor is exposure to long working hours. This is a fundamental change in what we are finding in these new estimates.
And you had a specific question to ILO. We'll go to colleagues and see if they have that answers, or we'll have to.
The work-related burden of diseases, we know that is disproportionately carried by people living in Africa, no surprise, Southeast Asia and Western Pacific. Is carried by male and by older people.
And over to ILO for further.
Africa, Southeast Asia, and the Western Pacific are most affected. And within these regions, we can also say that low and middle income countries are more affected than high income countries. And I think this points to your question also on more disadvantaged workers, specifically informal economy workers. So this is certainly part of the epidemiological explanation of why we see larger burden in these regions and then in low and middle income countries within the regions. Right? So informal economy workers probably work in jobs that have less protection and therefore are exposed to more occupational risk factors. Thank you very much, Emma. Long working hours are now the single biggest occupational risk factor, and we only established this 3 months ago, right? So with our estimates in 2021, unbelievable indeed, we found the largest risk factor for work-related burden of disease. This completely changes our thinking of where the risk is and where we need to focus our action on. In that regard, I want to highlight exactly as you said, long working hours have been increasing as a response to COVID national lockdowns. We know that about 10% more people now work in long working hours, or working time has increased by 10% across North America, Europe, and the Middle East from a study from the National Bureau of Economic Research.
Thank you, Dr. Nera. Does ILO wish to come in?
Convention 1 of the ILO was there to limit the number of working hours to a healthy limit, and this is 120 years almost later, I think, that we are sitting here and we have the first estimates of how many people die as a result of overwork and long working hours. So that really revolutionizes also our understanding of work-related burden of disease, right? One risk factor responsible for 1/3 of the total burden, and we only find it in 2021. For an epidemiologist, this is unbelievable.
Well, you've heard the people who were actually responsible for producing this path-breaking report. This particular report underscores the fact that we need to understand our environment, we need to understand the situation on the ground, and we need to estimate as to what is the real extent of work-related occupational health disease factors. One, what is the actual implication for our practice of occupational health? If you recollect, the Sustainable Development Goals, which are SDG 3 and SDG 8, which are to be attained by 2030 as part of the agenda of sustainable development, exposure to occupational risk factors and the attributable health loss must be reduced or even eliminated. This requires the monitoring of such exposures and health loss at country, regional, and global levels. For this purpose, the World Health Organization, that is WHO, and the International Labour Organization, that is ILO, they produced their first joint estimates of the work-related burden of disease and injury. This monitoring report describes the objectives, data sources, and methods of these interagency estimates and reports the WHO-ILO joint estimates generated in this estimation cycle. The WHO-ILO joint estimates have been produced within the framework of the Global Comparative Risk Assessment, in which exposure to specific occupational risk factor is linked to the specific attributable burden of one specific health outcome. For example, a disease or an injury, which is defined. For 39 established pairs of occupational risk factor and health outcome, the estimates are produced using population attributable fractions calculated from recent burden of disease estimates. For 2 additional pairs, population attributable fractions are calculated from new databases of exposure to occupational risk factors and risk ratios produced in WHO ILO systematic review and meta-analysis. The estimation methods used apply population attributable fractions for specific occupational risk factors to total disease burden, envelopes to provide estimates of the burden of disease attributable to the risk factors. In this estimation cycle, WHO and ILO have produced estimates for the 41 selected pairs of occupational risk factors and health outcome. All estimates are available for the year 2000, 2010, and 2016, reported at country, regional, and global levels, and are fully disaggregated by sex and age group. Globally, in 2016, a total of 1.88 million deaths and 89.72 million disability adjusted life years were estimated to be attributable to the 41 pairs of occupational risk factor and health outcome. Diseases accounted for 80.7% of the deaths and 70.5% of the disability adjusted life years, and injuries accounted for 19.3% of the deaths and 29.5% of the disability adjusted life years. All covered diseases are non-communicable diseases. The occupational risk factor with the largest number of attributable deaths was exposure to long working hours. That is 55 hours or more per week. It caused 7,44,924 deaths. It is followed by occupational particulate matter, gases and fumes with 4,50,000 deaths, and occupational injuries with 3,63,283 deaths. The health outcome with the largest work-related burden of deaths was chronic obstructive pulmonary disease with 4,50,381 deaths, followed by stroke with 3,98,306 deaths, and ischemic heart disease with 3,46,618 deaths. A disproportionately large work-related burden of disease is observed in the WHO African region, Southeast Asia region, in which India is situated, and the Western Pacific region, where Australia is situated. And it occurs in males and older age groups. This first set of WHO ILO joint estimates can be used for global monitoring of exposure to occupational risk factors and work-related burden of disease and injury. Also, it can be used to identify, plan, cost, implement, and evaluate actions to effectively prevent exposure to occupational risk factors and their associated disease and injury burdens. Now we actually see the contribution and how we actually see the 19 occupational risk factors and how each one is contributing to disease and death, and disability and death, and lowering of quality of life. Let's go to the next slide. Deaths due to occupational risk factors are particularly high, as I told you, people living in Western Pacific and Southeast Asia, people of older working age, and in men. Next slide, please. This again underscores the importance or essentiality of following the hierarchy of controls to prevent work-related health loss. What is most effective and what is least effective is shown in this diagram, where elimination is most effective and PPE, that is personal protective equipment, are the least effective. Elimination through physically removing the risk factor, substitution by replacing the risk factor, having engineering controls by isolating workers from the risk factor, administrative controls by changing how people work, and last, by using personal protective equipment to protect workers with equipment. Next slide. This is the overview of all pairs, that is for the 41 pairs of occupational risk factors and health outcomes for which estimates are available. Deaths are 18,79,890 and disability adjusted life years are 89.72 million. 89.72 million. This is the latest global estimate for the total 19 occupational risk factors. This is a graph which shows the total number of attributable deaths by occupational risk factors in 183 countries for the year 2016. This figure shows you how much contribution, the largest contribution is by the bottom graph, that is exposure to long working hours. And the second highest is occupational particulate matter, gases and fumes. And the third highest is occupational injuries. And the fourth is occupational exposure to asbestos and also occupational exposure to silica and occupational asthmagens, besides other risk factors. This graph shows you the total number of attributable disability adjusted life years by occupational risk factors in 183 countries for the year 2016. The highest is by occupational injuries, second is exposure to long working hours, and third highest is occupational ergonomic factors, and the fourth highest is occupational particulate matter, gases and fumes, and the fifth one is occupational exposure to asbestos, and then occupational asthmagens. These are the top 6 contributors to loss of disability adjusted life years. That is, it impacts the quality of life. Next slide, please. This is the total number of attributable disability adjusted life years by health outcomes in 183 countries for the year 2016. And look at the height of health outcome in stroke and back and neck pain and chronic obstructive pulmonary disease and ischemic heart disease and tracheal bronchus and lung cancer and also asthma and also motor vehicle road injuries, pedestrian road injuries, motorcyclist road injuries, other exposure to mechanical forces, other transport injuries, and other unintentional injuries. Besides other contributing factors. This is disability adjusted life years in millions. Now, we shall examine all the 19 occupational health risk factors separately and see what is the report saying about each one of them. Now, first we take up asbestos. This is the 2016 global estimate for occupational burden of disease attributable to exposure, occupational exposure to asbestos. Deaths 2,09,481 and disability adjusted life years is 3.97 million. 1,77,614 deaths and 3.29 million deaths as a result of tracheal, bronchus and lung cancers, an increase of 28.9% and 17.2% respectively from the year 2000. See the increase which has happened in the last 16 years. Second, 5,464 deaths and 0.10 million deaths as a result of ovarian cancer, an increase of 20.9% and 13.4% respectively from the year 2000. Third, previous slide, please. Third, 3,299 deaths and 0.07 million deaths as a result of larynx cancer, an increase of 12.5% and 3.8% respectively from the year 2000. Over the 16 years, look at the increase which has happened. So when the fourth aspect is 23,104 deaths and 0.51 million deaths as a result of mesothelioma, which is an increase of 81.9% and 56.8% respectively from the year 2000. Look at it, the increase, the sharp increase which has happened due to exposure to asbestos, and it has led to tremendous increase in the incidence of mesothelioma and for deaths and Delhi's lost due to mesothelioma. That's a glaring example. Now we come to arsenic as an occupational exposure to arsenic. The burden of disease attributable to occupational exposure to arsenic, 2016, 7,589 deaths, and Delhi's were 0.24 million. These deaths and Delhi's occur as a result of trachea, bronchus, and lung cancer, and increased 34.3% and 28.9% respectively from the year 2000. Third risk factor, next. Benzene, burden of disease attributable to occupational exposure to benzene, deaths 1,452, and Delhi's 0.08 million, and these deaths and Delhi's occur as a result of leukemia and increased 23.6% and 15.4% from the year 2000. Next, this is beryllium, the occupational exposure to beryllium. Burden of disease attributable to occupational exposure to beryllium, 165 deaths and 0.007 million Delhi's. These deaths and Delhi's occur as a result of trachea, bronchus, and lung cancers, and increased 63.4% and 44.5% respectively from the year 2000. Next, this is occupational exposure to cadmium. Burden of disease attributable to exposure to cadmium, 452 deaths and 0.02 million Delhi's, and these deaths and Delhi's occur as a result of trachea, bronchus, and lung cancers, and increased 62.0% and 46.8% respectively from the year 2000. Next, please. Burden of disease attributable to occupational exposure to chromium, deaths 1,022, Delhi's 0.04 million. These deaths and Delhi's occurred as a result of trachea, bronchus, and lung cancer, and increased 64.8% and 51% respectively from the year 2000. Next, burden of disease attributable to occupational exposure to diesel engine exhausts, 14,728 deaths, and Delhi's 0.47 million. These deaths and Delhi's occurred as a result of trachea, bronchus, and lung cancers, and increased 61.6% and 55.1% respectively from the year 2000. Next, burden of disease attributable to occupational exposure to formaldehyde, deaths 743, and Delhi's 0.05 million. For nasopharynx cancer, 327 deaths and 0.02 million Delhi's, an increase of 24.3% and 12.3% from the year 2000. For leukemia, 416 deaths and 0.03% million Delhi's as a result of leukemia, an increase of 18.9% and 9.3% respectively from the year 2000. Next, burden of disease attributable to occupational exposure to nickel, deaths 7,301, and Delhi's 0.03 million, 0.23 million. These deaths and Delhi's occur as a result of trachea, bronchus, and lung cancers, and increased 34% and 28.6% respectively from the year 2000. Next, burden of disease attributable to occupational exposure to polycyclic aromatic hydrocarbons, deaths 3,881, and Delhi's 0.13 million. These deaths and Delhi's occur as a result of trachea, bronchus, and lung cancers, and increased 59.8% and 50.9% respectively from the year 2000. Next, burden of disease attributable to occupational exposure to silica, 42,258 deaths and 1.3 million Delhi's. These deaths and Delhi's occur as a result of trachea, bronchus, and lung cancers, and increased 32.4% and 27.4% respectively from the year 2000. Next, this is burden of disease attributable to occupational exposure to sulfuric acid, 2,564 deaths and 0.09 million Delhi's lost. These deaths and Delhi's occur as a result of larynx cancer, and increased 15.1% and 12% respectively from the year 2000. Next, burden of disease attributable to occupational exposure to trichloroethylene, 25 deaths and 0.002 million Dallies due to kidney cancer. These deaths and Dallies, and they increased 316.7% and 87.6% from the year 2000. Next, occupational asthma Jains, 29,641 deaths and 2.1 million Dallies due to asthma, and decreased 16% and 0.1% from the year 2000. So there is a advantage in terms of asthma Jains. For particulate matter gases and fumes, look at the number: 4,50,381 deaths and 10.86 million Dallies. These deaths occurred due to chronic obstructive pulmonary disease and decreased 4.9% and 1.8% respectively from 2000. Next, occupational noise. No deaths are attributable to occupational noise, and Dallies 8.16 million. Other hearing loss is the result, and that is the reason for the death, for the Dallies loss, and there has been an increase of 38% from the year 2000. Next, burden of disease attributable to occupational injuries. Deaths 3,63,283 and Dallies 26.44 million. So we have to see deeper. Road injuries, 72,000 deaths and 4.24 million Dallies due to pedestrian road injuries, which is that there has been a decrease of 8.4% and 6.7% from the year 2000. 12,018 deaths and 0.93 million Dallies due to cyclist road injuries, which is an increase of 10.1% and 19.3% from the year 2000. 48,151 deaths and 3.25 million Dallies result of motorcyclist road injuries, which is an increase of 14.8% and 15.8% from the year 2000. 76,946 deaths and 4.64 million Dallies as a result of motor vehicle road injuries, increase of 13.4% and 12.6% from 2000. 1859 deaths and 0.23 million Dallies as a result of other road injuries, which is an increase of 5.4% and 33.9% respectively from the year 2000. 16,864 deaths and 1.58 million Dallies as a result of other transport injuries, decrease of 21.9% and 15.2% from the year 2000. For poisonings, 3,772 deaths and 0.21 million Dallies due to poisoning by carbon monoxide, decrease of 49.1% and 48% respectively from 2000. 5,330 deaths and 0.34 million Dallies as a result of poisoning by other means, a decrease of 49.1% and 45.7% from the year 2000. Look at falls, 34,996 deaths and 3.73 million Dallies as a result of falls, a decrease of 4.9% and an increase of 5.4% respectively from the year 2000. Fire, heat and hot substances, 10,234 deaths and 0.92 million Dallies as a result of fire, heat and hot substances, decrease of 36% and 23.4% respectively from the year 2000. Next slide. Road injuries, poisoning, falls, fire, heat, substances. Next. Burden of disease attributable to occupational ergonomic factors. No deaths attributable to occupational ergonomic factors. But look at Dallies lost, 12.27 million due to back and neck pain, where there's been an increase of 20.1% from the year 2000. Next. Exposure to long working hours, very, very important. Deaths, 7,44,924 and Dallies, 23.26 million. 3,98,306 deaths and 12.6 million Dallies as a result of stroke only, an increase of 19% and 21.7% from the year 2000, and 3,46,618 deaths and 10.66 million Dallies as a result of ischemic heart disease, an increase of 41.6% and 41.2% respectively from the year 2000. Look at the global increase in 16 years in ischemic heart disease caused by long working hours. So this is definitely the most important contributor for deaths and valleys, the long working hours exposure. And one must find ways to contain this exposure risk factor. Now, besides this data, there is an interactive chart which is available online, which I'll show you, where you can see the country-wise data. Let's look at the interactive chart, and which will help you in understanding. No, not this one. The graph which shows you the contribution, and you can change the parameters and see the data for each country or each region separately, and that gives you a really grip on the subject. This is the way it comes. WHO ILO joint estimates, shinyapps.io, and it is an interactive. You have to reload. Yes. Now you will see the map coming. On the right side is the parameters: occupational risk factor, exposure to long working hours, cause. You can change the cause, stroke and ischemic heart disease. You can measure. Now just point the cursor to India. And just press. Keep it pressed. This graph will come where rate per 1 lakh population of deaths from stroke attributable to exposure to long working hours in 2016 for India has come, for age group, for male, female, male, and both. And this, you can see how age factor and each graphically you can see how each exposure and what is the impact on each individual age group. Just press outside, this will go away. Now, instead of stroke on the cause on the right side, just press the menu. You can change it to ischemic heart disease and press the again, bring it to India when the map comes. Yes, put it. See, rate per 1 lakh is 12.1, and this is for ischemic heart disease. It has come out graphically once you keep it pressed. Now press outside. Right, and instead of deaths, you just drop down the menu and see disability adjusted life years. Right, so it will show you disability adjusted life years. Similarly, you can change unit. Just take the cursor to unit, cursor, number, and population attributable fraction. For year, you can see the years. Just take the cursor to year. Year is 2000, 2010, and 2016. The data will come for that particular year, and you can take the cursor to that country, and you will get the data for that country. All right. Then you can take out the data for sex, for age group separately as you go on the right side menu. Sex, both sexes, male and female separately you can take. Right. And similarly, you can go to age, and each age group you can see separately for each country. So it is a really interactive website where you can see the occupational burdens of disease, and you can get the data. You can get disaggregated data. You can get it on a map, and very effective tool for understanding as to what is the specific risk you have to control and how much control will give you how much impact. A very, very useful website, very useful tool that is available. So for this, I'm grateful for you to have your time so that we can discuss now this burden of disease, occupational health risk factors, how the WHO ILO have worked together for the last 5 years and produce this important document.
Thank you, Dr. Rajiv sir, for this particular session. and this particular topic about this workplace risk factors which have been estimated by WHO, ILO combined, and the joint report has been submitted, and it is quite important to know that long working hours, that is the major cause of the disease and disability right now amongst the workers. And now, because of the new norms of working, uh, people are working. Um, there are no fixed timings for work at home also. So long working hours, they are causing a lot of occupational health risk factors for the workers, and that is a major cause of death also due to this particular disorder. And the risk factors at work which cause the most deaths per year, that is also quite alarming, that it is long working hours, they are causing about 7.5 lakh deaths, and air pollution and gases and fumes, which for which a lot of controls have been installed by various industries and governments. That too is causing 4.5 lakh deaths and injuries, 3.6 lakh deaths. So out of these three risk factors, like air pollution, injuries, they are being already taken care of. Now what is alarming is the long working hours, for which I think still we have to work a lot, and there are no controls on this, and there are no regulations or no a hierarchy of control to prevent this particular hazard, and to prevent our health, workers' health from long working hours. So this was a really very good session. May I request our respected panelists, if they have any question, they can unmute themselves or they can raise their hands so that I can take up their question. There is one question in Q&A box by Dr. Subhendu Mudgal. I take that estimate of burden of disease of arsenic is done for the occupational exposure in work environment, not as natural pollutant leading to community exposure. Isn't it true? Please confirm. This is from Dr. Subhendu Mudgal, our fellow of AESD also.
Very, very important, Dr. Shubhendu, very important clarification you have sought. Yes, the occupational exposure in work environment has been taken for calculation of both deaths and DALIs for this estimate. In fact, if there are two reports, the second report is only detailing the methods used and the data sources. And for each data source, the reference is there. It's a 92-page report. I have only shared the key findings. One should, for all occupational health practitioners, they should read both the reports together, because one is actually the results, but the second, which is absolutely technical, where the data sources and the methods and how these methods have been applied to those data sources is laid out in detail. So but your question is very relevant. One has to actually estimate the exposure in the work environment. Natural pollutant, of course, it also causes, but when you say occupational exposure attributable risk, then you have to say attribution in terms of work environment exposure to arsenic.
So there is one comment from Dr. Jagdish Patel. He is saying, thank you, Dr. Jain, for this presentation, and you are so quick. Yes, Dr. Jain is so quick, and this session was planned because of the yesterday report, which was jointly released by WHO ILO, and it was very well planned in advance. We will have it this session and totally on this particular topic along with the COVID Epid update, so that it is quite relevant. If the things we take after a long time, when it is known to everyone, then the importance of the things, it goes down. But right now these things are very relevant, and I think long working hours, that is clicking in my mind again and again, and that we have to take care. Dr. Vivek Chand Rao, sir. would you like to say something, sir?
Yeah. Good evening, Sandeep. Good evening, everybody. Thank you very much, Dr. Jain, for the update. You're so crisp and you've given complete update to us. We are very much thankful to you. IOH is thankful to you. But I mean, it was so scaring to know that long working hours. By definition, you are given more than 55 hours per week. But I don't know, especially when people are working from home. I don't know the Indian mentality. We continue to work at home, even though it was not work from home, even our regular working hours. We still think of our office, we still work. I don't know how these ILO, WHO estimates work, especially after knowing that asbestos exposures, there's an increase in number of malignancies from year 2000 to 2010, 2016. I'm really surprised. They are just estimates. On what basis they do? Because as per the experience of Dr. Richard Doll, who have studied thousands of people, textile workers in UK, and Dr. J.C. McDonald, who have studied thousands of asbestos miners and asbestos cement workers, they have estimated the number of diseases will come down after the year 2000 onwards. But these estimates, ILO, WHO, are showing increasing in numbers. In spite, asbestos is not used in most of the countries, and that has been in reduced usage from 1980 onwards. But ILO, WHO estimates are confusing. Let me go through the report before I make further comments. Thank you very much, Dr. Rajiv.
Yeah, thank you, Dr. Vivek Chandra.
Yeah.
Actually, this is what is expected, because unless we are convinced of the methods used and the validation of those methods, one should not take on face value. This is the exact purpose of this first estimate, official estimate by the WHO ILO. Always there has been a difference of opinion, but when we talk of comparative risk assessment method for burden of disease estimation, we follow a standard terminology and a standard methodology so that these figures could be comparable for each risk factor, because these 41 pairs is just the beginning. There'll be more in future. So it is equally important that the methodology is critically looked at by all the practitioners of epidemiology and occupational health practice, whether they are in the developing country or the developed country. When we say distribution of exposure to risk factor in the population and the risk ratio of health outcome when exposed to risk factor, that leads to the population attributable fraction. And if you multiply this by total burden of disease estimates or health outcome which are available, in the
I have been asking WHO at least for last 2 decades. You always speak of estimates. Why don't you speak of actual number of cases? So they are not ready to further discuss on this subject.
No, if you, I would rather request you to go to the interactive chart and go to the technical report, which is 48-page report, which will answer all your queries. In fact, each particular aspect is looked at, and exactly what you were thinking has been also looked at, because asbestos has been a very controversial issue in terms of actual number of cases and its contribution to cancer causation. 81 incidents have been doubted upon, but what we have, fortunately, asbestos has got the largest collection of systematic reviews and meta-analysis on the ground. And they are based on actual ground studies, validated and published in peer-reviewed journal. Then evidence rating also makes a difference. When we say quality of evidence rating, high, moderate and low, that also makes a difference. Then we say evidence ratings in terms of sufficient evidence of harmfulness, limited evidence of harmfulness, or inadequate evidence of harmfulness, or evidence of lack of harmfulness. These are the factors. And also, when we say data sources, whether these data sources are reliable, they come from a well-established group of scientists, that also makes an important contribution to trusting these data, because unless you go through the technical report of 48 pages released with a 92-page estimates report, so 92-page one report and 48-page one report together, if you read as a occupational health scientist or epidemiologist, then I think it would be proper to actually give suggestions to the World Health Organization, ILO, and that is exactly the purpose. We must communicate to WHO, ILO, and Dr. Maria Nera, I can give her email. You can give through email, and that will be also worked upon. Actually, this data comes from thousands of occupational health experts, epidemiologists, scientists, toxicologists, which has resulted in this 92-page report over 5 years. And this is, I'm really happy with your presence, because your long association with the occupational health movement in our country makes it very important that we understand the science behind these estimates. Thank you so much.
Thank you, Dr. Vivek Chandra Rao, sir. So a good discussion. And I thank Dr. Rajiv for being agile and swiftly bringing all the latest developments to our focus, so that we can go through and take some necessary actions in our respective organization. May I request Dr. Shyam Pingle, sir, our International Commission on Occupational Health board member, who is there, and
Thank you.
yeah.
Thank you, Dr. Sandeep.
Thank you, sir.
It's an excellent presentation. And Dr. Jain is having a very bad effect on me. Now I have stopped reading because Dr. Jain does all the reading on my behalf and gives me summary and concise information. Thank you, Dr. Jain. I mean, it's wonderful. And thanks a lot. I see Mr. Jagdish Patel having raised his hand. If he's still around, we will like to hear about him, because he's an activist and he also has a lot of interest and exposure in the field. Thank you.
So, Dr. Jagdish Patel.
Yes, he's raised his hand.
Yeah, you can speak, sir. Now you are a panelist.
Thank you, Dr. Pingle, for noticing my presence and my hand. And thank you, Dr. Sandeep, for giving this opportunity. Actually, this finding that long working hours is killing workers is though not very astonishing. Now there is an official support from ILO and WHO that long working hours are killing workers. So in 2009, I had an opportunity to meet the Chief Inspector of Factories of Gujarat. I wanted to interview him for my magazine in Gujarati, which I was editing, called Salamati, which was exclusively on health and safety at work. And we were completing 100th issue. So I interviewed him and I asked him that invariably, if you go to any industrial area in Gujarat and you ask any worker randomly, he will be saying that he is working for 12 hours. So we have factories act which require worker to work only for 8 hours. So why this is the situation and what actions you are taking? So what he replied was that we have now stopped prosecuting employers for violating this provision for 8 hours. Why? He said that because our judiciary is taking so long time that if we are filing any complaint in the court, then our inspectors have to attend the court every time, and every time the hearing is postponed, and it takes a long time. And therefore, and we don't have adequate manpower with us, so we cannot afford wasting the time of our inspectors, and therefore we have completely stopped prosecuting employers for violation of these working hours. So we will have to now look at the data of prosecutions in all the states all over India, how many prosecutions are being done for violation of the working hours. That is one. Second thing is that there was a cap on overtime in a quarter. Earlier it was 75 hours, and then government became liberal and it raised that time to 100 hours. So you can extract overtime for 100 hours in a quarter. And usually seen, I have worked for more than 20 years in factories and have seen that in most cases, nobody looks at whether in a quarter you have crossed 75 hours or not. So that provision is also not being enforced. And so now there is the Occupational Health and Safety Code. Again, I think it is very concerning about the working hours. So overall, the picture is not very encouraging, but we should thank WH and ILO for these estimates so that we will have now power to generate awareness on the killing effect of the working hours. Thank you.
Thank you, Dr. Jagdish Patel, sir, for highlighting this particular issue. And yes, the Occupational Health and Safety Code, it is also quite concerned about this long working hours, and we have to abide by the restrictions of the overtime, and we should deliberate in our industries that our workers, they should not cross like 75 to 100 hours of working overtime per quarter. So these are the things which we should stress upon. And in addition to that, after this COVID, because of the long working hours and at home also, as Dr. Vivek Chandrao sir has also told, whether these estimates have been taken in consideration or not, because at home we are always at work, because we can be called at any time by our seniors for any video conferencing or some like official job. So how we will estimate this working hours when we are working from home? So that is also very important. So yes, now this concern which Dr. Rajiv sir you have raised is very important, and we will take care of this, and we will try to make more raise more awareness amongst our workers, our employees about the long working hours, in addition to the air pollution and the injuries, which are the leading cause of deaths across the world in our occupation.
In fact, Dr. Patel has raised an important aspect, and taking this into consideration only, the WHO ILO together have issued these estimates. And as you know, the WHO is a collection of 183 countries, and ILO is also official body for the governments of 183 countries. And ILO convention, in fact, ILO convention number 1 stipulates not more than 48 hours per week. It is the implementation and the commitment of the member countries at their national level and the state level, which they have to find a way out for actually ensuring. Now, what is the way? The ILO says tripartite. And what is tripartite? The government on one side, employers on the other side, and the workers and their representatives on the third side. These three forces, stakeholders, should sit together and find ways and means to ensure that these facts, these official data are taken into consideration for practice on the ground. Now, these data are to be used for advocacy, for lobbying, for presenting the evidence to your employers, and also showing that it will harm long-term productivity of that organization, because the person exposure will lead to incidence of ischemic heart disease, which will be the cost of which will be borne by the employer, as well as in stroke incidence will also increase substantially, the cost for managing a stroke patient will also be borne by the employer. So why not control these risk factors and ensure that the person remains healthy and leads to higher productivity and higher profitability of that industry or that company or that organization or that part of the economy in the long term. Unless you have estimates which are official, the starting point would not have reached. And that is precisely the reason why these estimates have been made out and officially released yesterday evening. In fact, this very issue was being discussed in the 1 hour deliberation yesterday when I was attending from 5:30 p.m. to 6:30 p.m. yesterday. In the discussion, this was occurring again and again as to what will be the way forward to ensure the further reduction of these risk factors. A very important point, Dr. Patel, you have raised. I've been reading your writings with interest for so long. Thank you for taking the time to attend.
So, thank you, Dr. Rajiv. A great discussion on the long working hours. And yes, long working hours, they are causing a lot of ill health, lot of loss of productivity. And in 24/7 industries, the fatigue is also very important, and that causes that is because of the long working hours, especially the night shifts and the long shifts. So this also need to be taken care of. And like in Indian Oil Corporation, we have designed our own fatigue management guidelines as per the risk management strategy, as per the API 755. And this is the way we all should work in our industry towards managing and controlling the long working hours, leading to ill health or leading to death or leading to the loss of productivity. So this was a very good session. And the second topic for today is our regular COVID Epid update, because the pandemic is still going on and it is evolving with different shapes. Like although the numbers are decreasing in India, and yesterday we covered more than 2.25 crore of vaccinations on the birthday of our respectable honorable Prime Minister of India, and that was really a landmark in the history of vaccination. And may I request Dr. Rajiv Kumar Jain sir to start his COVID Epid updates so that we are aware of the latest developments about the evolution of the pandemic. Dr. Sir.
Yes, of course. Now we should refresh the epidemiological situation of COVID-19 as it is evolving in our city, in our country, in our continent, and in our WHO region and in the world, and see what is happening on the ground. Let's go ahead and take a review. This is the overall global review, and in the graph, what do you find? You find the third wave is very much on globally. The first peak, second peak, and the third peak. Look at the wave after wave, as if it will keep on going ahead like you wave in an ocean. And look at the black line, that is the line of death, the cases of deaths. If you look at first, second, third peak, and after that, the fourth peak, which is a lower peak, is at the moment globally is on. If you look at the numbers in the next slide, overall, out of 100 cases, 37% cases occurred in Americas, 28% in Europe, 12% in Southeast Asian region, 8% in Eastern Mediterranean region, 12% in Western Pacific region, in Africa, only 2%. But if you look at the change over the last 7 days and current 7 days, overall in the world, there will be 13% decrease and 17% decrease in Americas, 5% decrease in Europe, 16% decrease in Southeast Asia, 15% decrease in Eastern Mediterranean region, 8% decrease in Western Pacific region, and 15% decrease in African region. All regions of the world have shown decrease from the previous 7 days. If you look at the deaths, out of 100 deaths that occurred in 7 days, 38% occurred in Americas, 23% occurred in Europe, 14% occurred in Southeast Asia, 10% in Eastern Mediterranean, 10% in Western Pacific, and 5% in Africa. But if you look at the trends of deaths on 7 days versus 7 days, only 2 regions have shown increase. Western Pacific 2% increase and African region 7% increase in deaths week on week. Overall in the world, 7% decrease, with the largest decrease in Southeast Asia, 20% decrease. 9% decrease in deaths in Americas and 2% decrease in deaths in Europe. That is week on week. Next slide. This is the overall picture of the 6 WHO regions, and look at the way things are happening. On the left top, the yellow one is a region of the Americas. You are seeing first, second, third, and the fourth wave at the moment. If you look at the yellow graph. And on the right top is the European region in the green, light green. And there again, you find 1, 2, 3, and fourth wave going on at the moment. But look at the African region. There, it is the third wave which is going on at the moment. And Eastern Mediterranean region, again, you see a different kind of graph where each wave is higher than the previous wave. First, second, third, and the fourth wave, and the fourth wave is the highest. Now you look at bottom left, the violet color, Southeast Asia region, you have a moderate first wave, but very, very high second wave, and a moderate third wave at the moment in the Southeast Asia region. But look at the diversity of the structure of the graph and look at Western Pacific in purple, you find each wave higher than the previous wave. And the highest wave, that is the fourth wave, is on at the moment in the Western Pacific region. And look at the difference between the third wave and the fourth wave. At the moment, they are in the thick of the fourth wave. How much diverse the world is, but the fact remains, globally, as I showed you in the first graph, the world is going through the third wave of the pandemic, globally, if you see, overall. But each region of the WHO is showing a different trend. Next slide. This is the overall picture as on date, taken half an hour back. Last 7 days, 37,69,000 cases, out of which 14,49,000 in Americas, 11 lakh in Europe, 3.84 lakh in Southeast Asia region, 2,51,000 in Eastern Mediterranean region, 4,75,000 in Western Pacific region, 1,02,000 in African region, and that is what has happened last 7 days in the different regions of the WHO. Look at the countries next. The top country in terms of 7 days cases was United States, 10,54,000 cases out of 37 lakh total cases in the world. United Kingdom with 2,06,000, and India number third, 2,06,000. Turkey 1,76,000, Philippines 1,42,000, Iran 1,40,000, Russian Federation 1,31,000, Malaysia 1,29,000, and Brazil 1,06,000. And Thailand also reporting 95,000 cases over 7 days. Next, look at the deaths, ranking of the countries in terms of deaths in the last 7 days. Out of 63,000 deaths which occurred globally, 13,000 deaths occurred in United States of America, Russian Federation 5,461 deaths, Mexico 4,493 deaths, Brazil 4,176 deaths, Iran 3,137 deaths, Malaysia 2,869 deaths, India 2,239 deaths, Vietnam 1,955 deaths, Turkey 1,733 deaths, and Indonesia 1,707 deaths. So you find all the continents and everywhere the deaths are occurring across the world. Next slide. This is the global graph showing COVID-19 cases per 1 lakh population reported by countries, territories, and areas. And darker the color, higher is the cases reported in the last 7 days per 1 lakh population. The darkest is more than 3 lakh per 1 lakh per 1 lakh population, 300 per 1 lakh population. Darkest color is brown, and you see USA, and you see Mongolia, and you see these cases. Even UK, you see which is the darkest color. It's across the world. Next slide. This is the COVID-19 deaths per 1 lakh population reported by countries, where the darkest color, that is the dark blue, is more than 6 deaths per 1 lakh population. Is there, you find this color is also there in Africa. This color is Southeast Asia region, and also few countries in Europe. You are seeing deaths are also very high if you see in terms of per 1 lakh population. Next. This is the trend in Southeast Asia region. Southeast Asia region reported substantial decreases in new cases and deaths with over 4,53,000 new cases and over 8,900 new deaths, decrease of 16% and 20% respectively as compared to the previous week. Overall, regional deaths have declined consistently over the past month and a half. And this week, all countries in the region reported decrease in weekly cases and deaths as compared to last week. Notable decrease reported in Indonesia, 30% decrease for cases, and Bangladesh, 33% decrease for deaths. Highest number of new cases were reported from India, 248,248, 15% decrease. Thailand, 101,000 with 5% decrease. Indonesia, 338,491 new cases, 30% decrease. Similarly, the highest number of new deaths were reported from Indonesia, that is 3,028 new deaths with 23% decrease. India reported 2,122 new deaths with 21% decrease, and Thailand 1,498 new deaths with 13% decrease. So the trend is overall good towards the decrease in cases and deaths overall, and that's what is shown in the graph as well. Now we look at the snapshot for India. Last 24 hours, 35,354 new cases, 285 deaths, and 15.5 lakh tests yesterday. 7-day average test positivity is still above 2% for entire India. 3.3 lakh active cases are there, but they are shrinking at minus 2.1%. Total 3.34 crore cases have been reported from India with 4,44,563 deaths, and 79.6 crore vaccination doses have been given, with highest single day vaccination yesterday, as Dr. Sandeep was telling, 2.5 crore doses were given yesterday on the occasion of our birthday of our Honorable Prime Minister. This is the overall picture with confirmed cases. Kerala, Maharashtra, New Tamil Nadu, Andhra, and Mizoram are topping in terms of confirmed cases. In deaths, it is Kerala, Maharashtra, Karnataka, and Tamil Nadu and West Bengal are at the top 5. Tests per million per day, highest are being conducted by Mizoram, Andaman Nicobar, Ladakh, Jammu Kashmir, Kerala, Delhi, and Goa. But lowest are being conducted by Rajasthan, West Bengal, Nagaland, Chhattisgarh, Madhya Pradesh, and Uttar Pradesh. On the other hand, if you look at the 7-day average test positivity rate, Kerala is still showing 17% test positivity rate, and Mizoram is showing 15.9% test positivity, and Manipur 7.4, Sikkim 6.7. So it is actively spreading in Kerala, Mizoram, Manipur, Sikkim, and Meghalaya, and Maharashtra. If we look at 7-day average daily growth, it is very high in Mizoram, 1.5%, Kerala 0.44%, Meghalaya 0.24%, and Manipur 0.18%. If you look at vaccinated persons with at least 1 dose in percentage, lowest has been now in Nagaland, Meghalaya, Jharkhand, Bihar, and Uttar Pradesh at the bottom on the right, on the green color, light green color. Next slide. This is the spread of the alpha, beta, gamma, and delta variant of concern across the world. Now, if you look at alpha, it is in 193 countries, beta is in 142 countries, gamma is in 96 countries, and delta has now gone to 180 countries. And India is having all 4 variants of concern. Next slide. This is another data which has been brought out this week: incidence and mortality in children, adolescents, and young adults. Overall, there are proportionately fewer cases and deaths from COVID-19 among children, adolescents, and young adults as compared to adults. Based on age, disaggregated case data, reported to WHO from 30th December 19 to 6 September 21. The proportion of global cases increased with age category. Children under the age of 5 represented the smallest proportion of cases among individuals up to 24 years old, while older adolescents, that is 15 to 19 years old, and young adults, that is 20 to 24 years old, grouped together had the highest proportion of the global cases. Deaths for all age groups represented less than 0.5% of the proportion of global deaths. Next slide. Children and adolescents infected with SARS-CoV-2 generally present with milder symptoms of COVID-19 disease, although infection with variants of SARS-CoV-2, including the Delta variant, require more investigation to determine if this will remain the same. The risk of transmission to and from children and adolescents depends on contextual factors such as the level of community transmission and the measures implemented to control the virus. Host factors in the child, as well as the biological factors related to the virus itself. However, children and adolescents of all ages become infected and also transmit SARS-CoV-2 to others. Younger children may be less susceptible than older children and adolescents, but the precise role of children and adolescents in the overall transmission of SARS-CoV-2 still requires further investigation. The use of public health and social measures, including physical distancing, cleaning hands, cupping into a bent elbow or a tissue, adequate ventilation in indoor settings, and masks for older children should be consistently and appropriately implemented for all age groups in schools, especially since children under the age of 12 years are generally not yet eligible for vaccination. That is the official statement from the World Health Organization. Countries are pushing to vaccinate the children. Top experts in the US and UK said over the weekend that they expect children of younger ages to be covered in the COVID-19 vaccination drives in their countries soon. In US, 5 to 11-year-olds by October end. In UK, by 12 to 15-year-olds in weeks. That is what officially the former Food and Drug Administration Commissioner Scott Gottlieb said, that he expects authorities to approve rollout of the children in age 5 to 11 by the end of October. And in UK, reports said on Sunday that the UK government plans to announce COVID vaccination for 12 to 15-year-olds across the country with mass inoculation beginning in schools within 2 weeks. And last week, according to the Guardian report, UK's Joint Committee on Vaccination and Immunization stopped short of recommending COVID jabs to those under 16. The country has allowed for anyone 16 and above to take the dose. Which countries are giving it to children? In total, 51 countries have allowed children of at least some age groups to be eligible for COVID vaccines. In most cases, these are for children over 12 years of age. And which vaccine is being used? Mostly the shot being used in children around the world has been made by Moderna and Pfizer-BioNTech. Both of these have shown to be safe in children, and their efficacy in preventing COVID-19 has been established. Should children get a vaccine? The WHO said that children at higher risk should get vaccinated, but those who are healthy must not be a priority. It has also been said more evidence needed on the use of different COVID-19 vaccines in children to be able to make general recommendations on inoculating the children. What is the argument against using them? UK's JCVI has advised caution, saying follow-up studies in children has been only for a limited duration. The committee said benefits are only marginally greater than the known harms if children are not vaccinated. It did not take into account the gains in schools resuming. What about India's approach? Several vaccines are being tested in minor volunteers in India, of which Zydus Cadilla's Zycov-G has been given emergency approval, but the official recommendation has not yet changed to cover children. Next slide. Vaccination is now on the up, but inequities remain. In mid-June, the US, Germany, and the UK, the richest 3 of the world's 15 most populated countries, had each administered at least 75 doses of the COVID-19 vaccine per 100 population. Coverage in the poorest 4 in the group was languishing in single digits, with the exception of India. But some have accelerated their coverage since then and narrowed the disparity. This is what the latest data shows. 15 June and 14 September, coverage expanded by over 3 times in Bangladesh, 5 times in Philippines, and 18 times in Vietnam as supply constraints eased. In June, the coverage in the US was 15 times higher than that of Bangladesh, but now it is only 5 times. In countries with more than $30,000 GDP per capita, Japan was a laggard with low coverage in June, but it has managed to quick ramp up since the Olympics. While the progress has been good, it is not enough. Bangladesh vaccine coverage is only around 21 doses per 100 population, Vietnam's 30, and the Philippines 35. Globally, vaccine distribution has fared worse. By last week, 40% of the global population received at least 1 dose, but the figure was only 2% in low-income countries. There have been efforts to boost vaccine supply under the COVAX initiative and to dissuade rich nations from providing booster doses. However, this requires higher levels of international cooperation. Meanwhile, India is reportedly facing pressure to resume vaccine exports, which is threatening to slow down its own vaccination drive. Next slide. This is the same information shown in a graphical format. The poorest countries ramped up vaccination in past 3 months, but coverage remained low. And Bangladesh led the most populous countries in vaccine coverage growth this past week. Next slide. 30 of the 36 states and UTs have given over 500 doses per 1,000 population. India has administered 219 million doses in the past 30 days, comprising 44% of doses it has given in the past 3 months. It has increased its vaccine coverage to 554 doses per 1,000 population, currently from 191 doses per 1,000 population in mid-June. Assam, Madhya Pradesh, and Tamil Nadu increased coverage by 4 times in this period, with 1,027 doses per 1,000 population. Himachal Pradesh continues to lead the larger states. Himachal Pradesh, along with Sikkim, Dadra and Nagar Haveli, and Daman and Diu, Goa, Ladakh, and Lakshadweep have covered 100% of the adult population with at least 1 dose. However, Uttar Pradesh, Bihar, Nagaland, and Meghalaya lag the national average. While Bihar and Uttar Pradesh have been consistently behind, Nagaland and Meghalaya have slowed down in the last 2 months. Their cumulative vaccination coverage grew by 63 doses per 1,000 population last month compared to 89 2 months ago. Next slide. This is the Kerala impact. Kerala district reported over 10,000 new cases each in the last 7 days. With 140,552 new infections in the past week, Kerala continues to account for about 68% of all new cases in the country. It also hosts all of India's top 10 districts with the highest number of cases. Thrissur reported 70,429 cases in the period, followed by Ernakulam 16,503 and Thiruvananthapuram 13,733. However, there is a silver lining. In the top 10 districts, cases have declined by at least 7.2% in the past week. At a state level, Kerala reported a 27% reduction in cases, a key factor behind a similar reduction in the all India number. The northeastern region, another hotspot, also witnessed an improvement over the past week, with the exception of Mizoram, where cases rose by 3.6%. In the rest of the country, Tamil Nadu and West Bengal reported a 4.5% rise in cases since last week, and cases went up in 19 of 32 districts in Tamil Nadu. Next slide, please. This is Tamil Nadu reporting a steady rise in deaths in the past week. India reported 2,178 deaths in the past week, down by 2% from a week earlier. Haryana, Goa, and Tamil Nadu are the only states to have reported an increase in the number of deaths. Haryana reported 122 deaths this week, up from 9 last week due to a reconciliation exercise undertaken by the state health department. Goa, too, added 77 deaths after a similar exercise. Tamil Nadu reported 173 deaths, up 31% from the prior week. With 986 deaths, Kerala has the most number of COVID-related fatalities, even though the toll was lower by 5.2% since last week. It is followed at a distance by Maharashtra with 315 deaths, down 32.4%. Both Tamil Nadu and Kerala have demanded more vaccines from the center to control the infection spread. As the festive season beckons, averting a third wave will be on the mind of all state governments. Himachal Pradesh is leading the country as vaccine pace maintains the momentum. Next slide. This is the national vaccination drive of peak levels, but pace remains very high. You see the graph, how much pace it has attained over the past 9 months. Next slide, please. Himachal Pradesh leads all the states with Kerala and Uttarakhand not far behind. And if you look at top right in the graph, Himachal Pradesh, Kerala, Uttarakhand, Gujarat, and Delhi and J&K are there. But on the bottom left, you see Uttar Pradesh, Bihar, Jharkhand, Tamil Nadu. And that is what is causing concern. Next. The states are still maintaining an impressive pace. If you look at new doses administered per million adults, Kerala, Haryana, Madhya Pradesh, Uttarakhand, Karnataka are giving good number of new doses administered per million adults in the last 30 days. Next slide. What is needed to cover all adults by end of December? While the pace of the drive has seen improvement, particularly from the low rates seen in previous months, data shows that there is still room for progress. If India wants to achieve its stated target of vaccinating its entire adult population of 940 million by the end of 2021, a commitment the government has made in a submission to the Supreme Court. In total, India needed to administer around 1.88 billion doses by the end of the year to meet this target. Since 765 million of these doses have already been administered, that leaves around 1.115 billion doses to be administered the remaining 107 days in the year, or 10.4 million doses every single day till December 31. When the country has come close to matching, even exceeding this required rate on a few days, it has not been able to do so on a daily basis. So it has to maintain consistency. Having 2.5 crore in a single day yesterday was very good, but the pace has to be maintained in the more than 2.5 months that are left for, or 3.5 months that are left for this year, 31st December, when we say we will administer at least one dose to all the people, all the adults in our country. As Simone Weil said, attention is the rarest and purest form of generosity. I must thank you for your attention and your generosity. You're muted, Dr. Sandeep.
Yeah, thank you, sir, for giving a broad overview of this COVID pandemic. And still, we all need to be very careful. And the vaccination drive, yes, it has to be accelerated. And yesterday, more than 2 crore vaccinations were done. So we have to gear up our vaccination in this regard. If you have any question from the audience or panelists, they can unmute themselves and they can raise the question. There is one question by Dr. Damodar Lele, but I am not finding his question. His query is why his question has not been answered. Dr. Lele sir, you can unmute yourself. You can directly ask your question.
Hello.
Yes, sir.
See, it is this way.
Yes, sir.
Ground reality is perhaps not known to all. The contract labor normally work for 12 hours. And they put that condition because they want to earn as much money as possible when they are in a migrant state in the different state. That is first thing. We don't know this reality. It is happening all across. Second is, right now during COVID, most of the employees are working for more than 12 hours. That has been discussed already. And they are working in most unsuitable ergonomic positions. See, and third is this new labor code. It is going to say that workers can work for 12 hours a day. Okay. And they are going to abolish about 13 laws, including Factory Act. Now, any comments on this?
Well, Dr. Lele, you have raised very relevant questions. And in fact, to manage these questions, one has to have data. And now, officially, country-wide data for each risk factor is available. And these are official WHO ILO data. And that was the purpose of sharing the data with you. Now the action has to be taken on the ground by joint efforts of the government, employers and employees and their representatives. That is the spirit of actually moving forward on all the risk factors, and not only long working hours. I also mentioned number of other occupational risk factors. They are also important. If you look at road traffic injuries, if you look at occupational noise, if you look at back pain, or you look at neck pain, or poor ergonomics, they're also contributing substantial loss of disability adjusted life years besides long working hours. Long working hours are contributing highest to stroke and ischemic heart disease. Now, in fact, the study was initiated from that point, and the first release was in May this year. That was done for long working hours. Now we've got actual data for 19 with 41 occupational risk factor. This is the first step. Till now, as Dr. Frank Pico was also mentioning, if you look at the working hours regulation, ILO convention number 1, it was there for more than 120 years, but nobody estimated the contribution that long working hours cause for ill health, as to what are the group of diseases that it is causing and what is the attributable risk. For the first time, officially, WHO, ILO together over the last 5 years, they've been working since 2016, and in 2021, during the pandemic, they brought out this data. For what purpose? Exactly for the purpose that you were mentioning. The purpose is to raise voice, to ensure that people understand, the employers understand, the employees understand, and the governments understand that there is a risk attached, there is a cost attached to long working hours. And that purpose is fulfilled when you understand that in COVID times, additional contribution due to work from home or due to fuzzy distribution between official work and home work is causing additional burden. In fact, yesterday this issue was discussed, and a study on this aspect will be carried out, and you will get the data on contribution at occupational attributable risk due to WFH will be estimated, and you will get the actual figures in the years to come. That is what the WHO and ILO committed yesterday. Thank you for asking this, raising this important issue.
So, any other question? So, if there's no question, then definitely, sir, we have to, as an association, we have to raise this voice, and as industrial physicians, we have to make our management and employees understand the risk attached with the long working hours, and we should understand this for ourselves also, because we all had been working for long working hours, maybe working from home or working from our offices. So all these risk estimations, they have enlightened us that what all are the risk factors we need to take care. And still the COVID vaccination drive, we have to more focus on. And with the coming festive season, we all request you all to take care, special care, because government has also told that next 2 to 3 months, they are very crucial, and vaccination is not a guarantee for not getting infected, but it will definitely reduce your seriousness of the infection and hospitalization and fatalities also. So we have to propagate this message of vaccination and taking all COVID appropriate norms. And with this, sir, we would like to conclude this session. And this was a lovely session with the occupational health, industrial health, COVID is also an occupational disease right now. So if we take the estimate because of the COVID, how many deaths they have occurred, so that I think that will be the number one before this long working hours. So with this, sir, We'll come out with a new topic next time, and this particular presentation will be available on our YouTube channel, Enoch DigiConnect webinar channel, and it is being live telecasted over there also. So at your leisure time, you can always refer to it. You subscribe it, and all the videos are available of all our 69 previous webinars. So thank you very much, sir. Thank you, Dr. Rajiv Jain, sir.
Thank you so much.
Thank you and good night.